Good evening. I welcome all the dignitaries on dais. This is our journal journey, academic feast for all the practicing pediatricians. Today is 1st May, Maharashtra Din. And it is very special day here also because our coordinator, Dr. Narendra Naniwadekar sir, had translated the parental guidelines in Marathi, and 98 episodes have released till date. या पालकांसाठी मार्गदर्शक तत्वाचे प्रणेते, मेंटर डॉक्टर पीयूष गुप्ता sir, our central IAP president, welcome sir, is also present for this episode, which is very, very important. महाराष्ट्र दिनाच्या या सुवर्ण कांचन योगासाठी आपण असं ठरवलेलं आहे की 100वा एपिसोड, 100व मार्गदर्शक तत्व आपण आज सरांच्या हाताने प्रसारित करणार आहोत. यासाठी मी नरेंद्र नानिवडेकर सरांना विनंती करते की त्यांनी त्यांचे जे ऑनगोईंग 98 एपिसोड झालेले आहे पालकांसाठी मार्गदर्शक तत्व मराठीमध्ये आपल्या सर्व प्रॅक्टिशनर्सला पाठवलेले आहे आणि सर्व पालकांना त्याचा खूप फायदा झालेला आहे. याबद्दल त्यांनी आम्हाला सांगावं. ओव्हर टू यू नरेंद्र सर.
जय महाराष्ट्र. महाराष्ट्र दिनाच्या सर्व IAP च्या आमच्या बांधवांना आणि भगिनींना शुभेच्छा. सर्वप्रथम मी नमूद करू इच्छितो की हे आपले पालकांच्यासाठी जी मार्गदर्शक तत्व जे आहेत त्याचं भाषांतर माझ्या बरोबर अनेक जणांनी केलेलं आहे आणि आमची अख्खी टीम यासाठी कार्यरत होती आणि त्याची प्रेरणा आम्हाला डॉक्टर पीयूष गुप्ता सरांनी दिली. ज्यावेळेस मी EB मेंबर होतो, जेव्हा आमची पहिली मीटिंग झाली आणि मार्गदर्शक तत्व निघणार आहेत असं समजलं, तेव्हा आमच्यात त्यावेळेसचे आमचे सगळे जे EB मेंबर्स होते आणि व्हाईस प्रेसिडेंट डॉक्टर जयंत उपाध्याय सर होते, तर त्यावेळेस आमची चर्चा झाली होती की मराठीत येणं गरजेचं आहे. त्यावेळेस नुसती चर्चा झाली होती पण त्याच्यावरती आमची ऍक्शन काही झाली नव्हती. पण यथावकाश आम्ही त्याच्यावरती ऍक्शन घेतली आणि गतवर्षीचे महाआयपीचे प्रेसिडेंट डॉक्टर हेमंत गांगुलिया त्यांनी त्याच्यात निश्चित पुढाकार घेतला आणि अमोलनी तर मुलाची साथ दिलेली आहे. सर्व टीम मेंबर्सची नावं मला आता सांगणं शक्य नाही, पण मी एवढं नमूद करू इच्छितो की सर्व माणसांनी अतिशय मेहनत घेऊन ते मराठीमध्ये ट्रान्सलेट करण्याचं काम केलं आणि त्याच्यासाठी आम्ही एक प्रोसिजर तयार केली होती. सरांसाठी मी मुद्दामून ते आता इंग्लिशमध्ये सांगतो. Sir, what we did was we tried to choose those who are interested in translating these guidelines into Marathi language, and we kept a filters where one person used to translate these guidelines, one pediatrician used to check this from the pediatrician's point of view, and then we used to give this to a literary person who was a non-medico to check for the nuances and checking that the flow of language was well maintained and it was easy for the parents to understand. Once that was done, we used to give it to the person who used to do the PDF work, and once that was done, we used to recheck for any mistakes which were there, and the technology has helped us to correct those mistakes easily. And fortunately, with stipulated time, we have been able to complete this. There are 105 guidelines, so very soon 105 guidelines will be translated into Marathi, and as Amol has already put in that these guidelines are available on the MahaIAP website, so very soon this will be a complete picture on these guidelines. And I sincerely thank all the MahaIAP officials as well as all my team members, and the review was done including Dr. Upendra Kinjodekar, who despite his busy schedule had checked a few of my translations, and he has reviewed them and he has given his valuable suggestions. So I thank all of you and I thank all my team members. And on 105th, I am going to request Amol and Ramakant both to have a special episode where I will be asking all the team members to talk, because today is not the time where we will be able to talk. All of us will be able to talk. So at that 105th episode, we will definitely have a program where all of these people who have contributed will come on the platform and will have a chit chat over the Zoom meeting. So now I hand over the proceedings to Dr. Piyush Gupta sir, who will be unveiling the 100th guideline. Piyush Gupta sir, please.
Namaskar, good evening to all, and Jai Maharashtra. It's such an auspicious day today, and you are releasing the 99th and 100th parental guideline in Marathi. You don't know how delighted I am. When I was the president at that time, that was my dream, that I'll be able to translate all these guidelines into at least first 10 Indian languages. But unfortunately, I could not complete that task, and you have taken it to the ultimate. And today is the 99th and 100th release. I am thankful to the coordinator, Dr. Narendra Naniwadekar, who had the guts, Dr. Hemant, president at that time, and the entire team. Now today we have Maha IAP and team IAP Raigad here who are doing this program. So I really congratulate the office bearers, Dr. Ramakant Patel, Dr. Amol, Dr. Vikas, Dr. J. Kohli, and then most importantly, all those who contributed to the development of these guidelines and translated. Hats off to all of you. My big salute to the entire team. And I am really happy that, and this will be of immense benefit. I am happy that the work is getting forward. And in fact, Dr. Narendra has even offered that to translate this in Hindi for all. So I said, okay, if nobody else is doing, and if the president agrees, you can go ahead with it. So that is between you and the president. I am most happy whenever such work, because इस काम करने का कुछ मिलता नहीं है, सिर्फ एक सेटिस्फेक्शन मिलता है, अपने मन में एक संतुष्टि मिलती है कि देश के लिए, जनता के लिए, बच्चों के लिए हमने कुछ किया. और यही हमारी एक आईएपी की जो एक मूलभूत भावना है, जिससे हम जुड़े हुए हैं इंडियन एकेडमी ऑफ पीडियाट्रिक्स के हर स्टेट के लोग. सो दैट इज व्हाट कैरीज अस forward. Thank you very much once again for giving me the opportunity to be here. I usually sleep by 8 or 8:30, but I said no, I'll keep awake for this program, and so that I can be with all of you. Thank you once again. I am most happy to release the 99th and 100th guideline today with all of you. Please go ahead.
Dr. Neha, आप guidelines दिखाइए.
Sir, this is the 100th guideline.
Yeah.
Sir, you can declare it as open.
I declare this 100th guideline as open. Great. Thank you.
Thank you, sir. Thank you.
Soon it will be circulated.
This is Atul Gupta, so
various
I think this should be about the chronic disorders or the some flag.
Yes, sir.
Yes.
Sir.
I remember each guideline by its
Yeah.
Atul and me, sir.
Yeah. I remember. Thank you so much. Wonderful.
Thank you so much. आपण आता कार्यक्रमाच्या पुढच्या भागाकडे वळूया आणि आपल्याला वेलकम करायला आपल्याकडे एक नवीन मास्टर ऑफ सेरेमनी आज जॉईन झालेले आहेत. आमच्या रायगड IAP सदस्या आणि स्वतः डेव्हलपमेंटल पीडियाट्रिशियन आहेत, डॉक्टर शिल्पा नंबियार. ओव्हर टू यू, शिल्पा.
Thank you so much, ma'am. Good evening to all the respected seniors and friends, and Jai Maharashtra. With the spirit of Maharashtra Day, we will go forward for our program today with another enlightening episode of Journal Journey, interesting articles and proficient experts. So Journal Journey is being successfully conducted on every first of every month under the able guidance of Dr. Neman Mohanty sir, started by IAP Raigad and in collaboration with Maha IAP. To start, now I invite Dr. Neha ma'am, our very own IAP Raigad member, Dr. Neha ma'am, Women's Forum co-chairperson, to say a few words and welcome our guests.
Thank you, Dr. Shilpa. Good evening, all. Today, on the occasion of Maharashtra Sthapna Divas, I, Dr. Neha Singh, co-chairperson of Maha-IP Women's Committee. Extremely elated to welcome all the respected dignitaries, seniors, friends, and who have joined us through Zoom as well as YouTube Live. I feel delighted to welcome our guest of honor, respected Dr. Piyush Gupta sir, for today's journal journey. I also welcome Maha-IP President and Executive Board Member, Central IP, Dr. Ramakant Patil sir, Secretary General Maha-IP, Dr. Amol Pawar sir, all the EPs of Central IIP like Dr. Jitendra Gavani sir and Maha-IP. I welcome our Maha-IP past president and mastermind behind this journal journey, Dr. Hemant Gangolia sir, Dr. Jay Bhandalkar sir, Dr. Neeman Mohanty sir, Dr. Chitra Kulkarni ma'am. I welcome both the experts of today, Dr. Parmarth Chandani and Dr. Jayashree Shivalkar ma'am, and the presenters, Dr. Bharat Chaudhary and Dr. Aishwarya. I also welcome Raigad IP President, Dr. Vikas More, Dr. Ajay Kohli, Secretary, and other EB members. Now I hand over to Dr. Shilpa for further proceedings. Over to you, Dr. Shilpa.
Thank you so much, ma'am. Now I request our Maha-IP President, Dr. Ramakant Patil sir, to address the session.
Thank you, Shilpa. And we have got an honor of having the Adhvaryu of IAP and who has also been past president of CIAP 2020, and he is a teacher par excellence, a distinguished teacher, and the recipient of Distinguished Teacher Award from Vice President of India. In addition to be an author, a researcher, a thorough academician, but most important, writer of so many books and periodicals and even the same chapters, but is par excellence teacher and teacher of teachers. And it is really great honor for this Maha-IAP and Raigad IAP to have guest of honor. And these path-breaking parental guidelines had been really accepted all over India. It is as educative as to the parents, but equally to the pediatricians, how they can explain it to their parents. And it is really being a lighthouse. And I really congratulate the team of Maharashtra, who is led by Dr. Narendra Nanedekar and ably supported by our Secretary, Dr. Amol Pawar. And in very short span, in nearly 4 or 5 months, we have got nearly 99th and 100th parental guideline being translated in Marathi and unveiled by whose idea, whose brainchild is this, by Dr. Piyush Gupta sir. It has been a great honor to be sharing the virtual dais with Piyush Gupta sir. Today also, I will like to congratulate Raigad team it is the brainchild of this journal journey of Dr. Hemant Gangolia, and it has been relentlessly, steadfastly, and consistently, without any fail, has been brought to the fore. And consistently, in spite of health issues, Dr. Neeman Mohanty sir has guiding all the speakers, all the presenters of article, and we are really thankful to Neeman Mohanty sir and his Herculean task and steadfast efforts. Thank you, sir. And it is really been brought to fore by Raigad IIP, and Dr. Chitra Kulkarni madam is consistently looking after all these episodes, contacting all the presenters and choosing the articles and bringing all these presenters to Dr. Neeman Mohanty sir, and whatever correction, what are the take-home message, what is new addition of these articles. It is wonderful job being done, and I hope all the presidents and the office where in coming years will continue this activity of journal journey, and it will get refined in henceforth. As already the all welcome has been done, but we have got really distinguished experts today. In addition to guest of honor, Dr. Parmarth Chandani, who is a renowned pulmonologist, and Jayashree Shivalkar madam, who is a psychologist as well as a developmental pediatrician from Nagpur. And this journal journey, sir, I will like to bring it to your notice that most of the article presenters are from the remote area of or district places of Maharashtra all over, and most of them are young people. So today we have got one of the presenter of this article is Dr. Bharat, who is from Nandurbar and also a JR3 resident, who is from SMBT Medical College, Dr. Malavde, Aishwarya Malavde, and Bharat Mistry from Nandurbar. And I really thank Raigad IIP and continuous their efforts and able guidance from our Secretary General and Chitra Kulkarni Madam. Thank you very much. And I will not like to take much time, but we should have expert opinions after even experts. If sir is going to wait for 1 hour because he has got a wonderful habit of sleeping at 8:30, because one of my friends goes to sleep at 10 p.m. So we say that 10 p.m. you are sleeping so early. But now I heard that today sir is going to sleep at 8:30 p.m. We need to emulate most of us at least 2 hours after 8:30. We should go to sleep at 10:30. Then and then only we'll be able to wake up at 5:30 and do all our meditation and exercise. Thank you so much. I hand it over to Shilpa. Thank you, Shilpa.
Thank you so much, sir, for your kind. I request Dr. Vikas More, sir, to say a few words.
Please unmute,
You
doctor.
are on mute.
Please unmute.
Thank you so much, Dr. Shilpa. Jai Maharashtra to everyone. On the behalf of IIP Raigad, I am proudly welcome all of you, especially my President Ramakant Patil sir, Dr. Amal for his team for encouraging us to conduct this program regularly. And at the outset, I am so much thrilled to see Dr. Piyush Gupta sir virtually sharing the dais with him is like a dream come true. And it is a blessing for all of us to hear words from his mouth. And Dr. Nanudikar sir, who is a PALS expert, and also the mammoth work he has done is really incredible. And releasing the guidelines today on this auspicious day is really wonderful task. Then we are so fortunate to have Dr. Bharat Chandani and Dr. Shrivikal sir, madam, as an expert, and also Dr. Chaudhary and Dr. Malvade as a presenter, who are young budding pediatricians from the very like inner areas of Maharashtra. So the general journey is now reaching to the every bit of Maharashtra. Gradually, the people are taking up this journey very seriously, and it is just happening just because of the consistent effort being taken by our own respected Mohanty sir, and under his guidance, the kind of hard work Dr. Chitra madam is doing. I'm really thankful, and a person who is working tirelessly, but behind the curtain is Dr. Neha Singh, who also draft the messages, also helping designing the flyers. So she is doing a very wonderful job, and our old doctor, Vishal Raut. And Dr. Amal Paur is also guiding them very nicely. So it is a work being done by various people for almost over the month, and then you see these results. So I'm so happy to see again, visiting all of you again on the first day. So this is a very happy moment for me every month on the first day. So again, I congratulate all the presenters for their taking up this good topics, so that all of us regarding these topics. Over to you, Dr. Shilpa.
Thank you so much, Vikas More, sir. Now I would like to request our Maha-AP Secretary General, Dr. Amol Pawar sir, to please introduce Dr. Piyush Gupta sir.
Thank you, Dr. Shilpa. Thank you, Dr. Piyush Gupta sir, for giving consent, and you were there on time for this very important meet of journal journey, along with unveiling of the 100th parenting guidelines. Now let me introduce you. Dr. Piyush Gupta sir is a principal and professor of pediatrics at University College of Medical Sciences, Delhi. He has been awarded Outstanding Asian Pediatrician in 2022. He was a president of Indian Academy of Pediatrics 2021 and chairperson of Pediatric and Adolescent Nutrition Society of IIP in 2019 and 20. He has published 300 papers, 400 book chapters, and 45 books. He was an editor-in-chief of Indian Pediatric Journal from 2008 to 2013. He was a member of he's a member of World Association of Medical Editors. He has been awarded by Royal College of Pediatricians UK, American Academy of Pediatrics, IAP, NNF, and National Academy of Medical Sciences, India. He has been awarded as the National Teacher of Excellence Award in Medical Education by Vice President, India. Major initiative of him are usually workshops on thesis and scientific paper writing. And thrust areas are nutrition, child survival, and medical education. So welcome Dr. Piyush Gupta, sir, on this journal journey episode. Over to you, and welcome all delegates, speakers. Everything has been told by President Sir, Ajay Kohli, Vikas More, sir. So over to you, Dr. Shilpa.
Thank you so much, sir. And Dr. Piyush Gupta, sir, thank you so much for accepting to be the guest of honor. And we would like your blessings before we move forward.
Please carry on. Thank you so much. I'm so delighted to see young faces, and it's really a delight to see that the journal journey is being presented by people who are from far off areas. So this is really delightful. Dr. Aishwarya and Dr. Nandu, I think big hats off to you, and thank you so much for doing this. Thank you. Please proceed.
Thank you so much, sir. Now I invite our coordinator, Dr. Jay Bhandarkar, sir, to introduce our first expert, Dr. Parmanand Channe, sir, and our speaker for today, Dr. Bharat.
Yes, thank you, Shilpa. Of course, our expert is Dr. Parmanand Channe, sir. He's the MBS and MD in Diploma in Asthma and Allergy from CMC Vellore, and he's expert in sleep medicine as a diplomat of European Respiratory Society and IAP certified pulmonologist and bronchoscopist in bronchoscopy and pediatric pulmonology in Cincinnati Hospital, USA, OEO. And current destination is AP as a pediatrics at Wadia Children's Hospital, Mumbai, and head of the pediatric respiratory department, Wadia Hospital, Mumbai, and concerned pulmonologist. He specialized interest in the flexible bronchoscopy and allergies and cystic fibrosis. Thank you. Over to Shilpa again.
Now the first presenter is to be introduced.
Yes, Dr. Bharat Chaudhary is MBS from TN Medical College, Mumbai. This is from BJ Medical College, Pune. He's the director of Shri Sustain Hospital, Nandurbar, and practicing general practice since 10 years. Welcome, Dr. Bharat. Thank you.
Dr.
Bharat, sir, can you please share your
yes.
presentation?
Thank you, Shilpa. Yeah, am I audible?
Yes, sir.
Yeah. Good evening all. Jai Maharashtra. I am Dr. Bharat Chaudhary from remote Nandurbar. I welcome you all to this session of Journal Journey. At the outset, I'd like to thank the IIP Raigad and MAHA-IIP for giving me this opportunity to present before this august audience. And I will also like to specially thank them for calling me young, because this gray beard otherwise tells something else. So the title of this study is Effect of Intranasal Corticosteroids on Quality of Life and Local Microbiome in Young Children with Chronic Rhinosinusitis. Authors. Well, there are several Polish authors who have contributed to this study. Their names have been mentioned on this slide. These names sound quite alien to us, but we must admire and appreciate their hard work and dedication. Source. This study was published in one of the reputed journals, the Journal of American Medical Association, JAMA Pediatrics, published online on February 27, 2023. So, chronic rhinosinusitis is an inflammatory condition of the paranasal sinuses that most often cause chronic sinonasal symptoms. There is this European position paper on rhinosinusitis and nasal polyps published in 2012, which has defined CRS as the presence of 2 or more symptoms for at least 12 weeks, one of which should be nasal blockage, obstruction or congestion, or nasal discharge, either anterior or posterior nasal tree, and/or facial pain, pressure, or cough. The same definition has been used in this study. What the prevalence? The prevalence up to 10% of population and reported to be as high as is as high as 5 to 15% in Indian urban population. That's a huge burden. That means at least 5%. If we consider the lowest prevalence, that is 7 crores of our people are sleeping with chronic nasal blockage or congestion. So the question is, can we make their life easier? And that's the relevance of today's paper. So what was the need for this trial? Now, intranasal corticosteroid remain the first-line treatment of chronic rhinosinusitis in both adults and children. They are recommended because of their exceptional anti-inflammatory properties and their well-documented safety profile. There have been studies regarding their efficacy and safety in adults, but no such studies have been done in pediatric population. Secondly, the cause of chronic rhinosinusitis is not yet fully understood. A growing body of research suggests that the breakdown of sinonasal microbiome pattern may play a significant role in the development of chronic rhinosinusitis. However, further evidence is needed to corroborate this theory. Similarly, it's necessary to evaluate the role of innate lymphocyte cells. These innate lymphocyte cells have been criminalized in pathogenesis of several inflammatory diseases, but their specific contribution to the cause of CRS remains to be fully understood. With these three issues in mind, a randomized control trial was conducted. So what were the objectives? The objectives were to assess the clinical response in the form of symptomatic improvement, the immunological response in the form of change in inflammatory cell pattern, and the microbiological response in the form of change in microbiota. It was all analyzed after 12 weeks of intranasal corticosteroid in young children with chronic rhinosinusitis. So, place of study. It was basically conducted in pediatric allergy outpatient clinic in Poland between year 2017 and 18. Design. It was open labeled randomized prospective clinical trial. Design, setting, and participants. Now, written informed consent from the patient parents were obtained before any procedure or test were performed. Children aged 4 to 8 years with chronic rhinosinusitis diagnosed by ENT surgeons were enrolled. The criteria for CRS diagnosis were consistent with the 2012 European position paper on rhinosinusitis and nasal polyps guidelines. Now, what were the exclusion criteria? Now, these exclusion criteria were considered with the aim to remove any confounders that could potentially affect the study procedures or primary or secondary outcomes, including the composition and biodiversity of the patient's microbiota. And they included food allergy with respiratory tract symptoms, contraindication to nasal endoscopy or nasal mucosal biopsy, hypertrophy of third tonsil more than 60% of the nasopharynx, confirmed immunodeficiency, exacerbation of asthma requiring systemic glucocorticosteroids, obesity, exposure to tobacco smoke, patients who have received intranasal corticosteroid within 4 weeks, and patients who had acute respiratory tract infection diagnosed within 2 weeks before the initiation of this study. So patients fulfilling the criteria were enrolled and randomized to receive intranasal mometasone in an atomizer for 12 weeks, 1 application per nostril per day, and supplemental 3 ml NS in a nebulizer. The control group received 3 ml normal saline once a day for 12 weeks. 100 patients were enrolled, out of which 34 were excluded. 30 did not meet the inclusion criteria and 4 declined to participate. 66 were randomized, 44 were allocated to intranasal steroid group, and 22 were allocated to the control group. Anticipating the potential benefits of the therapy, the ratio of cases to control was taken as 2:1, so that more patients will benefit from the treatment. 2 lost to follow-up from treatment group and 1 from control group. Finally, 42 from treatment group and 21 from control group were analyzed. Now, the patients were examined twice at the beginning of the study and again at the end of intervention. During the visit, All the patients were evaluated for clinical, microbiological, and immunological improvement. A standardized questionnaire, the Sinus and Nasal Quality of Life Survey SN5 scoring system was used to assess the quality of life. This SN5 scoring system consists of 5 symptom clusters. 1, sinus infection. 2, nasal obstruction. 3, allergy symptoms. 4, emotional distress. And 5, activity limitation. It is evaluated on a 7-point scale with a higher score indicating more severe sinonasal symptoms. Secondly, the curated nasal epithelium sample was taken. The sample was meticulously transferred within 3 hours to the lab and subjected to various procedures, including genomic sequencing. The prokaryotic RNA 16S was sequenced. The 16X RNA has a slow rate of evolution, hence the gene codon of 16S RNA are used in reconstructing phylogeneity. Sequence variant of this RNA are clustered to operational taxonomic units. These operational taxonomic units are basically a proxy for species. So more the OTUs, richer the microbiome. Many more technologically advanced procedures were done to get a refined data to be compiled and compared. Thirdly, the nasal epithelium was digested and subjected to flow cytometry. It was analyzed using specific immune markers and differential count of innate lymphocyte cells, that is percent of ILC1, ILC2, and ILC3 was calculated. So while analyzing the results, various statistical tests were used to sum up all the variables were analyzed and compared. Both intra-group and in-between group comparison was done. A mean and standard deviation was calculated for each variable. Mann-Whitney test was applied to compare the mean between groups. P-value was calculated to evaluate the probability that any observed difference between groups was due to chance or whether the difference observed was really significant. So out of this 66 general enrolled, 63 completed the study. The mean age of cohort was 6.1 years with standard deviation of 1.3 years. 38 participants, that is 60.3 were male, and 25, that is 30.7 were female. Now, the clinical improvement reflected by the reduction in SN score was significantly higher in the intranasal corticosteroid group compared with the control group. SN5 score reduced from 3.6 to 3.1 in intranasal corticosteroid group, whereas it increased from 3.4 to 3.8 in control group. The p-value within the group was 0.001 and between group was 0.009, much less than the 0.05 cutoff. And look at the ILC3. This innate lymphocyte C3 values, they drop from 0.072 to 0.026 with p-value of 0.001, again indicating significant reduction in ILC3 abundance after 12 weeks of intervention. The microbiome diversity has increased from 3.82 to 3.92 in steroid group, whereas it has decreased from 4.08 to 3.77 in control group. This shows that microbiological diversity has inverse relationship with SN5 score. The intranasal group had a greater increase in nasopharyngeal microbiome richness. It has increased from 53.5 to 64 with p-value of 0.001 that again indicates significant improvement. Now to conclude, this RTC presented two crucial aspects of intranasal corticosteroids in the treatment of pediatric CRS. One, their clinical efficacy, and second, a significant influence on increasing sinonasal biodiversity. It also demonstrated that an increase in bacterial diversity correlated with the decline of clinical symptoms, implying a possible positive relationship. So what were the strengths and weaknesses of the study? So strength, it was a prospective study. Cases and control were well defined. A validated definition was used to minimize the diagnostic ambiguity. Robust exclusion criteria were followed to minimize the confounding factors. Finally, both subjective, that is SN5 score, and objective, biodiversity and innate lymphocyte cell count were analyzed. What were the weaknesses? It was an open label, hence it was liable to observe bias. Study population was Polish, different in ethnicity from our Indian population. Sample for microbial assessment were taken from nasal mucosa. It may not represent sinus microbiome. Sample acquired by functional endoscopic access. It's the gold standard representative sample. And finally, long-term efficacy and systemic side effects of intranasal corticosteroid has not been studied. The efficacy has been studied over 12 years. Whether it increases, persists, or decreases is not known. So we may not know how long we can continue. So take home message to the study is chronic rhinosinusitis is significantly prevalent. Prevalence is noted to be as high as 15% of population. Hence, it's a significant health problem. Intranasal corticosteroid with low bioavailability, like mometasone, should be used promptly and frequently in eligible candidate with CRS. Finally, microbial diversity and richness has a significant role in pathogenesis of CRS. Hence, we must use antibiotics wisely. This ends today's discussion on this study, and just a couple of slides on what the situation is in India. So in our setting, CRS is frequently associated with allergic rhinitis with or without nasal polyposis. It is also associated with bronchial asthma and infections. Also, we need to rule out underlying pathologies like immunocompromised state, ciliary dyskinesias, cystic fibrosis, and anatomical abnormalities of the osteomeatal complex. We have our own ICMR guidelines, which have divided CRS into 3 groups for treatment. CRS with purulent discharge, without purulent discharge or polyposis, and it should be treated with intranasal corticosteroids, along with general measures like steam inhalation, saline irrigation, and antihistamine sprays. Those with polyps should have allergist testing done. Avoid allergens, treat bronchial asthma if present, because it is commonly associated with bronchial asthma, and undergo allergen immunotherapy if affordable. And those with purulent discharge need appropriate cultures and be started on antibiotic or antifungal therapy accordingly. So what's the relevance of this study in our Indian setting? Now, the environmental factors like air pollution, particularly particulate matter, PM level, exposure to smoke, overcrowding, etc. are totally different in India as compared to Poland. Nonetheless, we must use intranasal corticosteroid more frequently and for a longer duration, along with saline nasal irrigation, as the first line treatment of CRS. Many of us are using it, but for 6 to 8 weeks. So we may try it for 12 weeks. Secondly, antibiotics have been mentioned in IAP guidelines for treatment of CRS, but in the light of microbial richness and diversity having an impact on pathophysiology, antibiotic use should be restricted to those with purulent discharge, that too after sending appropriate cultures. So thank you all for your patient hearing. Special thanks to Dr. Chitra Madam, Dr. Mohanty sir, and our own Dr. Amol Pawar sir for their valuable guidance. Thank you.
Thank you. Please stop share.
Yeah.
I request Dr. Parmanand Chandane sir to give his give
Dr. Paramartha. Sir, please unmute.
Good evening, everyone. Jai Maharashtra. Thank you, Maharashtra IAP, Raigad IAP, of all office bearers, Piyush Gupta sir. This is a special session, 99th session, and all. This study which Dr. Bharat has presented, actually, he has really read this article very well, and he has presented also really very well. He has actually gone into depth of this article, and he has basically gone beyond the article also into ICMR guidelines also. Now I've been called to talk about this article, and there are a couple of things that we should be knowing what is currently happening in this practice. First is allergic rhinitis, then it goes on to develop chronic rhinosinusitis, and then many times we have seen children who are presenting with symptoms like obstructive sleep apneas. Okay, so something that is because of allergic rhinitis going into adenoidal hypertrophy and all this. Okay, so we see 3 spectrums mainly for allergic upper airway problems. One is allergic rhinitis, second is chronic rhinosinusitis, and third one is obstructive sleep apnea, which is secondary to the tonsillar and adenoidal hypertrophy. Now, in all these 3 scenarios, nasal inhalers, this intranasal corticosteroid, that is ICNS, are being used. Indian market, currently we have mainly 3 types of ICNS available. One is mometasone, other one is fluticasone, and third one is budesonide. These 3 are. And nowadays there come in combinations also with this azelastine being added to this three corticosteroids. Now, as far as the age group is concerned, fluticasone has two molecules in the market, fluticasone propionate and fluticasone furoate. So mometasone and fluticasone furoate can be used in children beyond 2 years of age group, while rest are used beyond 6 years of age. The advantage of mometasone is it is a single day use, while others can be used once or twice a day, depending on the age group of the child. Now, without discussing much of this study is wonderfully done. There is no study published like this of use of ICNS in children, especially mometasone. Mometasone is one molecule where, as Dr. Bharat said, the bioavailability, the systemic bioavailability is very less. That means when we give to the children, we are not really worried about whether there will be systemic side effects of these steroids. Okay, so when we talk to the parents, and many of them are very well educated and all, they are concerned about the systemic steroid side. So mometasone is one molecule where the systemic bioavailability is very less. Okay, and that has been studied in this study. What they have looked for in this study is mainly three things. The children were 4 to 8 age group, and they used mometasone for 3 months, that is 12 weeks. They studied mainly three things. One is a microbiota, second is that scoring system SN5, and third is IGLC 3 levels. Now, none of the studies till now have studied this ICL3 levels in children. None of the studies till now. That's why this study is superb as far as the content. What I have, when I went through the details of this article, what I found was this study is sponsored by AstraZeneca. So when I was looking into these things, the funding and all, the study is a single center study done from a single hospital. So when you have a single center and not multiple centers, your data may be skewed data. It may be a referral center, it may be a primary health center, and then sometimes the validity of the studies comes into question. Second thing is the funding. When I was looking into the funding, AstraZeneca sponsored this study, which is into the market in a big way as far as this ICNS is concerned. Okay, so I'm not saying whether they have their own agenda, but we should keep all these things in mind. As far as the study is concerned, it has been wonderfully written, wonderfully done. What I felt is lacking in the study is multiple centers should have been included than one single center, so that the diversity of the data can be maintained. Second thing is they studied this for 3 months. So in those 3 months, you may not see a lot of side effects in children. Like I say, when I start on intranasal corticosteroids, and I tell them parents to come, and I always see the nasal cavity, because I had an experience of seeing nasal candidiasis of overuse of this intranasal corticosteroids. So the side effect profile has not been well studied in this study. Okay. Just as far as the limitations and the strength that have been concerned, this Bharat has explained it very well. What we need to take this from the study is, I feel, mometasone is a wonderful molecule. I have been using it for many years, about 2 years. Should be used once a day. We should be looking for, if it is an allergic rhinitis, we should definitely go for mometasone. There is no problem with that. If it's a chronic rhinosinusitis, we should be more careful. Are we dealing with the chronic rhinosinusitis with bacterial infection or without bacterial infection? If we directly upfrontly start these children on nasal corticosteroids, there can be a chances that the children can present from chronic rhinosinusitis with acute bacterial sinusitis. Okay, that we should be careful about. So if we have a doubt, it is always better to give a good course of antibiotic for 10 to 14 days and then start with this steroid, or simultaneously also can be started. Another thing is these children needs to be monitored long term for this improvement in the symptoms. Any child who is not improving with this intranasal corticosteroids should be further evaluated in the form of either a nasal endoscopy or maybe a CT sinus to see if there is any polyposis or orthosis associated. I think that's all from my side. I am ready to take any questions if there are.
Sir, we will be doing the question answer sessions at end.
Okay, okay, no problem.
Over to Shilpa.
Thank you so much. Thank you so much, Bharat Chaudhary sir, for such an insightful article, and Dr. Parmath sir for giving us the insights on what has not been mentioned and what we have to see more while doing the next article, while choosing the next article. Thank you so much. So now we go on to our next journal article, and next for introducing our next expert, I request our IIP Raigad President Dr. Vikas More sir to introduce our second expert and our speaker.
Dr. Aishwarya? Yeah. First, we have to introduce the expert. The second expert is Dr. Jaya Shivalkar, madam.
Our second expert is Dr. Jaya Shivalkar, madam. Dr. Vikas More, sir.
Shall I do?
Yes, ma'am. Ma'am, you continue.
Yeah, she is a very passionate developmental pediatrician. We have heard her so many times in the webinar, and she is a child and adolescent counselor. She is having very good fan following in her area of practice in Nagpur. She is a CWC member and expert committee member in Disability Board and president of AHA in 2019. Our second presenter, Dr. Aishwarya Purushottam Malavde, is a young dynamic resident of SBMT Medical College and Research Center, Igatpuri, Nasik. Over to Dr. Aishwarya for her paper.
Dr. Aishwarya, you may share your presentation.
Dr. Shilpa, will you please share?
Yeah, I can share.
Yeah, please. Recently, Dr. Aishwarya had tried, and then we have decided like that. Make it full screen, please.
Yes.
Good evening, everyone. Thank you for giving me this wonderful opportunity at a very young age by stepping in the fraternity of pediatrics. So today I'll have a review article with the title of Psychology and Developmental Behavioral Pediatrics and Interprofessional Collaboration in Clinical Practice. So the authors for this journal are Lauren Gardner, Jason Hangover, Tony Whitaker, and Ronald Spinell. The source for this journal is Pediatric Clinics of Northern America. It is taken from volume 69, issue 5, October 2022 journal, and the page number from 895 to 902. So starting with this journal, I would like to tell why this review article is being taken for today's discussion. So with the current global healthcare trends, there is a growing need for the interprofessional practice in collaborative care of the persons with the chronic medical conditions. The developmental behavioral pediatrics, it is a medical discipline that is characterized by the interprofessional practice with the encouraging emergence of the specialty in India and other developing countries. So there is an emergence and recognition of DBP as a subspecialty in India, and it should be coupled with the gaining need for the centers so that we can expand the scope for the provision of ultimate diagnosis and the management of the patient with the neurodevelopmental disorders. So I have found this review article relevant considering the Indian scenario with the growing awareness of the NDDs amongst the parents and also with the clinicians in the peripheries, and the emerging concept of the joint practice, which we can see in India, marking the essence for today's discussion. So the key points pertaining to today's discussion are the neurodevelopmental disabilities being a complex disorder and difficult to diagnose in a straightforward manner as other any medical disorder. So the patient gets benefited by interdisciplinary collaboration by improving the outcome of the treatment plans that we implement, as we see in further in this review article. So the interprofessional collaboration, it promotes early diagnosis, treatment, the recommendations given by the psychologists, and the integrated care of the patients and the families also. The families, they are actually more involved in this matter, as they are concerned is the child, their precious child, who is abnormal or the neurodevelopmentally not sound. So calming the anxious parents, it is one of the major important role of the pediatricians and the psychologists. When they come together in collaboration, the outcome that we provide to the patient is much more quality-wise better. So the collaboration of the psychology and the DBP is beneficial for the patient care and the healthcare professionals. Let's proceed with our review article. So the introduction for this review article, as it is taken from the United States. So within the United States, there is approximately 17% of the patients in the pediatric age group who are diagnosed with the developmental disabilities. So the rate of the diagnosis has been seen to be improved by the interprofessional collaboration, which was carried out in the USA. So the collaborative efforts of the pediatrician and the psychologist have to be taken into consideration, and the screening at the appropriate age of the child also helps in the better outcome of the patients. So the screening, it can be carried out at the 5, 10, 30 and 16 months of age. Screening of the specifically autistic spectrum disorder, it should be carried out between the age of 18 months to 2 years, as the child with autistic spectrum disorder will show the significant signs like difficulty in initiating the interaction, or not interested in the surrounding, not having the eye contact, behavioral abnormalities. So these all things can be seen in the patients with the autistic spectrum disorder. So proper screening should be carried out at the patient at the right time. The child with the who screen positive for neurodevelopmental disorders should be referred to the pediatrician. Here, the role of pediatrician is they would carry out skilled evaluation of the child, of the development of the child in various domains, like in language, social, cognition, and in other motor skills also. So by involving pediatrician along with the psychologist, it will be a best combo for provision of the proper management to the patients with NDDs. So the comprehensive developmental evaluation of NDDs may include the specialists in the developmental behavioral practices. So some of the specialists which can be included in this are the neuropsychologist, neurologist, neuropsychiatry, and special educators, the speech and occupational therapist can be included in this, so that the collaborative effort help in getting the fruitful outcome for the patients. So interprofessional collaboration in clinical practice, it is defined as 2 or more professions working together to resolve a complex process, and they have sharing of the respective areas of expertise. Professionals from the different areas of clinical practice, they come to achieve together by working together towards a shared goal. That is when 2 or more expertise come together to work towards a complex process, and the outcome of it will be the product of the assimilated knowledge between the 2 or more disciplines. So it will have the better outcome in the patients, and also it will help to gain the confidence of the parents or the caregivers, because they are the most apprehensive in this scenario, as considering NDDs as the taboo in India. So the crux for the success of interprofessional collaboration is cooperation, mutual respect, which helps in providing the quality care to the community of the patients. This article emphasizes on the collaboration of the DBP and the psychology in providing the clinical care to the patients with NDDs, that is neurodevelopmental disorder. So what are the neurodevelopmental disorders? It is defined as the phenotype that is not caused by 2 or more pathogenic variants in the genes, but it is in total a genetic event which is significant, which also has significant contribution from the environmental factors. So NDDs, these are introduced recently into DSM-5 guidelines. So DSM-5 NDDs include intellectual disabilities, communication disorders, autistic spectrum disorders, attention deficit hyperactivity disorders, then other learning disabilities and motor disorders like tic disorders. By grouping these varied conditions into as NDDs, it allows the clinicians to categorize the patient. It also helps to, once the patient is categorized, it helps the clinicians to quickly and effectively know more about the patient and to helps in early diagnosis and effective management of the patient. So it also helps to provide the clinically useful information about the treatment and the management with the collaborative efforts of 2 or more disciplines. So let's see how there is diagnosing of the neurodevelopmental disorder. As it is not a straightforward diagnosis as other medical conditions, there is over time assessment, diagnosis, and of the NDDs, which we extract from the clinical history which is given by the caregivers or the parents. So we have found in this review article that while assessing and the diagnosing of NDDs, there is significant overlap between DBP and the psychology. So both of these professionals can be properly trained in order to administer the standardized treatment guidelines or even in the enhancing the evaluation plans of the patient. So the target approach or the integrated approach towards the multiple source of information as in genetic testing, the birth history, postnatal history, or the complications arising out of birth, or the current symptomatology, which requires the high level of expertise to synthesize all information. This can be provided by the primary pediatrician, and along with that, the contribution from the psychologist will help in proper management of the NDDs. So psychologists here, they provide a diagnostic evaluation of NDDs under the diagnostic criteria of DSM-5. So the gold standard for diagnostic evaluation of the patient with NDDs, we will see here, the empirically sound diagnostic instruments, clinical assessment, caregivers report, and the behavioral observation that can be seen at with the patient at the presentation in the OPD. So these all things form the gold standard for diagnostic evaluation of the patient with NDDs. So what are the benefits of interprofessional collaboration? So when both the disciplines come together to work, it will increase the level of satisfaction of the treatment seeker and the families, that is apprehensive parents. So the research studies supports that interprofessional collaboration practice, it reports increased job satisfaction within the different disciplines which are involved in the collaborative practices. Also, it helps to boost the confidence, reduce the stress and chaos in the workplace. So by building the partnership between multiple disciplines, including the DBP and psychology, it allows most efficient delivery of the services to the patients in requirement. So according to American Academy of Pediatrics, it recognizes it as an important system of collaboration, and it also recommends that this type of collaboration would reduce the cost and help in effective management of the patient by provision of the effective, along with the effective use of resources. It will also improve the detection rate. It will also help in enlightening not just the clinicians in the peripheries, but also it will help to enlighten the parents to know the trigger points or for the prevention and the management of the case. So what are the barriers we see in the interprofessional collaborative practice from the neurodevelopmental assessment according to this review article? So the DBP, workforce, it struggles to meet the current demand. In the market, there are many NDDs which are not even diagnosed, or due to the parental denial and reluctance to seek the medical care. Not much are been seeking the help from the clinical practitioners. So the workforce also struggles to meet the current demand. The difficulty in fulfilling the DBP care, there are various reasons for it, like declining workforce, inadequate reimbursement, inadequate training to manage the complex cases, high demands to care coordination between various disciplines. These all things create difficulty in fulfilling the DBP care. So it doesn't address in this review article, the barriers are not addressed to the patients or the families facing difficulty related to seek the care. So what is the relevance of this article with our daily practice? So in our day-to-day practice, we come across multiple cases of NDDs. Along with the concern of treating the child, there is also challenge of making the apprehensive parents aware and make them accept the child's condition. So the major hurdle in the implementation of it is the denial of parents and their reluctance to seek the care for their own child. So the complete team of pediatricians, psychologists, psychiatrists, and neurologists with special counselors will be helpful in taking care of various concerns. So the interprofessional collaboration will help in better management of such case. So by this, we can also expect a favorable outcome out of it. So let's take one case scenario for better understanding of this review article. A 30-month-old male patient who is referred to DBP by his primary care clinician due to the parental concerns of the speech and the language delay with behavioral abnormalities and with picky eating habits. The primary care clinician also referred the child to the early developmental intervention program. So taking this scenario under consideration, evaluation by the DBP, it is usually carried out at 35 months, which includes medical, comprehensive developmental behavioral history of child and detailed family history in order to know more about the inherited disorders which can cause NDDs. So the DBP's developmental testing reveals in this patient that there was verbal, non-verbal communication delay, and also there was limitation in socialization, initiation of the interaction, or mildly repetitive behaviors were seen. So these all features we can see in autistic spectrum disorder. So the DBP refers the child to the psychologist for formal comprehensive psychological assessment. So the psychologist, when sees patient, he carries out clinical interview, then extensive evaluation of the behavior of the child by keen observation, and the standardized texting measures are being used for the evaluation of the child with NDDs. So the management part which was suggested by psychologist in this case scenario was, he recommended 20 hours per week of comprehensive behavioral treatment, twice weekly speech therapy, enrollment in special schools, and occupational therapy. Occupational therapy was carried out in order to make the patient more compliant, or to make the patient self-reliant, and help the guardians to train the child in to carry out his day-to-day activities without any help. So accompanied by timely patient counseling about the child's condition and training them for better fostering and nurturing of the child will also help in treating the condition which probably does not have the cure. So following the completion of psychological evaluation, the psychologist conferences with the DBP provider to discuss the evaluation outcome and the treatment recommendations that can be provided to the patient. So the take-home message from this review article is, the interprofessional collaboration between the psychology and the developmental behavioral pediatrics, it is beneficial for the patient to have the favorable outcome. The collaborative effort, it promotes high quality of integrated services to the patients, which can be even under one roof if there is joint practice, which we see the emerging concept in India. And the psychology and the DPP are the two disciplines. Through the collaborative practice, they provide interprofessional workforce to support the overburdened providers. So the established and emerging healthcare professional need opportunities to build the skills and the knowledge in interdisciplinary collaboration practice to integrate the professional practice effectively. So let's see. So also there we can we can see the application of this review article in Indian scenario. So collaborative efforts, it has shown to empower various disciplines in India and boosting the confidence of the care providers. It also helps to train the clinicians in the peripheries and to make them more sound with the knowledge of the NDDs. Also, from this review article, we got to know that the early psychologist involvement have made to have the positive results on the outcome of the patient. So as an initiative, every pediatrician can have once weekly psychologist invited in their clinics, and the collaborative effort for not just NDDs but other chronic disorders of the childhood, which can be like cystic fibrosis or type 1 diabetes mellitus, complex seizure disorder, syndromic child, asthma, cerebral palsy, or other NDDs. So by introducing the psychologist in the clinic, it will help to counsel the parents, and also it as these chronic conditions in the childhood, they may not have definite treatment. So counseling part will play important role in this case, and this will pacify the anxious parents and help them gain confidence to support and nurture their child through the less known NDDs. Thank you. Thank you for this opportunity.
Over to Dr. Jaya Shivalkar, madam, for expert comments.
Good evening, everybody. Thanks for having me here. Respected Dr. Piyush Gupta, sir, who was present here, and congratulations to the team. And President Dr. Patil, sir, and Secretary Dr. Pawar, and rest of the team. So thank you. And Dr. Aishwarya, it was a nicely presented scenario, though the writers or the team was not mentioned. So basically it is even the presentation of the article is by the collaborative effort of pediatrician and psychologist, or it is only psychologist who is writing this, or only pediatrician. So that also makes a little bit of difference. Definitely all the neurodevelopmental disorder, including ASD, we all know that multidisciplinary approach is always recommended. So having a psychologist on the board is definitely a welcome step. The article is from Western countries, so scenario may be little different there, where there are maybe less pediatricians and more psychologists. But in our setting, the conditions may be slightly different. Because pediatricians have more reach out even in rural area than psychologists. So these are the differences in Indian and Western scenario. Secondly, the term psychologist is repeatedly used in these collaborative practices. Psychologists basically deal with counseling part of the therapy. And usually we recommend the children respond to psychological counseling after a certain age. And where we are talking about neurodevelopmental disorder, and we all know that early diagnosis and early intervention is very important. So counseling the child may not be the primary approach for these children. Counseling the parents may be, yes, but we need a team of speech language therapists, we need occupational therapists, and of course, we need a trained developmental or even a routine pediatrician. And I must say that Academy of Pediatrics and IIP has taken initiative in training the pediatricians to handle these things in their day-to-day practice. Secondly, in our setup, as I have known, the curriculum of psychology doesn't actually focus on early childhood. It mainly deals with the disorders in maybe adolescent or maybe, in adults mainly. And they focus on the counseling part. While when we are talking about the developmental pediatrics, it is more of a developmental approach. It is more of a therapeutic approach, and we see child as a whole. Even the nutritional, the medical part of child's health, the neurological part, the syndromic part, all this is something which is to be taken primarily care by the pediatrician. So for older children or for parent counseling, the typical psychologists are definitely useful. But for earlier age group, even as one slide was seen where they have said that psychologists will refer to pediatrician, say at the age of 32 to 35 months. But we have children coming to pediatrician right from the birth, and now we have our immunization schedule along with the developmental milestone assessment. So instead of parent, we have less chance of parent going to psychologist at the age of 30 months of child and asking for any developmental challenges. Instead, it will be the pediatrician who would be recognizing this at the time of, say, immunization, or if the parent have concern right from the 9 months onwards. So definitely role of teamwork is there, but probably in this paper, the term psychologist is used on a broad base where probably they include the therapeutic approach in early childhood also. But in India, I think the early childhood, early intervention, early diagnosis, and the therapies are specialized practices, and the psychology curriculum may not take care of these things. But definitely in future, this collaborative practice is going to be there. It is going to be the need of the time also. On one hand, we need to train the pediatricians also to counsel, to give some time for these children. On the other hand, we need to train the psychologists to deal with early childhood issues. Another thing is the very important term which is used is interprofessional collaboration. So what we need here is a teamwork between the pediatrician and the other professionals. But again, in India, we may have a different scenario where once you refer the patient to some paraclinical or paramedical person, chances of getting back to the pediatrician are very less because of the basic inherent insecurity and the other barriers. So I think we still need more time to train the psychologists, to depend on them for early childhood therapies or care. But more importantly, we need to train the pediatrician, and under the pediatrician's care and guidance, maybe these other other professionals or paraprofessionals are required. But at the end, NDT, any neurodevelopmental disorder, teamwork is very important. We need a multidisciplinary approach, but actual role of psychologist is in the care of older children and parents. That is what I think.
Thank you so much, ma'am.
Yeah.
Thank you so much, Jayashree ma'am.
Thank you.
That was really insightful. We actually need to create a team which consists of not just the psychologist, but therapists, occupational speech, everyone.
And basically, we need to train the parents.
Yes.
And the other difference which is seen if the child is under care of some other therapies is that they give the compartmentalized therapy. Child is going to OT for 1 hour, in the evening going for speech. What we need is a comprehensive approach which is usually adopted by pediatrician, where we are training the parents for combination of all these therapies, as well as involvement of parent in day-to-day activities also, along with the other medical care which is being provided by the pediatrician.
Thank you so much, ma'am. And thank you, Dr. Aishwarya, for sharing this article with us.
And congratulations, Dr. Aishwarya, nice presentation and nice topic taken up.
Thank you.
I request Dr. Niman Mohanty sir to please say a few words.
Thank you. See, both the presenters have done a very good job. They have given a very clear message. See, the limitation of these journal clubs is they have to discuss the paper as it is. Don't give extraneous comments outside the paper. Once they finish that paper, they can give an application in our own scenario. That's they have very well done. One thing is that we will now circulate these papers in advance to the MahaIAP platform. If you just go through it a little bit, then come after that, it will be better to understand. Like this review article is very long. She has to concise this. So many things cannot be brought out. As madam was pointing out, things are all there. But we could not bring everything here on this platform because of shortage of time. So that sorry for that. But she has done a very good job, young resident. See, we have seen that after the medical colleges, MD Pediatrics, many of our busy practitioners, they become engrossed in their own practice. They don't look at these journals if there's no time what to do this journal club. We thought this will be interesting or entertaining for them also while reminiscing the past. We thought of this and we want to ensure that this goes to the practicing pediatricians than the academicians and all the of course the young residents who are enthusiastic like Dr. Aishwarya. So it's a good platform to offer to them. Thank you very much. Well done.
Thank you, sir.
Thank you so much, sir. There is one question in the chat box for Dr. Parmarth sir. Sir, are you there?
Also, we request Dr. Jay Bhandarkar sir to ask the question.
Hello.
Yeah.
Sorry.
Parmarth sir, there is
Yeah,
a
I'm
question
there.
for you. Yeah.
So there is a question for you. Fluticasone furoate, it has to be given in OD or BD doses?
Furoate is once a day, propionate is twice a day. Okay. The dose that is given with furoate is 55 micrograms. Okay. And if the child is not responding, then we'll have to give them double the dose. That can be 110 micrograms, but that has to be, the 55 microgram has to be given for at least 6 weeks to say that it is not working and we are doubly sure that the diagnosis is correct. Then we can give it 110 micrograms provided the diagnosis is correct. So furoate is once a day, propionate is twice a day.
Thank you so much, sir. So we come to the end of today's journal journey. It was a very wonderful articles presented and discussed. To give the vote of thanks, may I request Dr. Chitra Kulkarni ma'am to do.
Madam, before that, I have got one question. May I ask it?
Yes, sir,
Yes, sir,
please. Yeah.
To Dr. Parmarth, is there a difference between toxicity of propionate and furoate molecule? As the claim has been there that furoate is more metabolized only in respiratory mucosa. How far it is that this claim is true, and how long we can give this, and when we can taper the intranasal steroids? That is one question. And one comment on this thing, very nice presentation from both Dr. Bharat and Dr. Aishwarya. But what did this review article add to it? Because what I find that we all are knowing that there should be interprofessional rather than interdisciplinary coordination should be there. Only thing is that most of the time when we come to the end of the road, then and then only we seek the opinion of other interdisciplinaries. But whether what did add this, whether it was just a sensitization for a proactive interdisciplinary approach or something has been added by this article or review article?
So first to Dr. Parmarth about the furoate and propionate.
Yeah. So the thing is, sir, when we talk about this, all the intranasal corticosteroids, as far as the side effects are concerned, we look at what is called as a bioavailability of this molecule when we give the molecule nasally. Now, if we want to list these medicines as far as the bioavailability is concerned, because that is what is going to cause the side effects. So the maximum bioavailability, the molecules which are available in the market, not Indian markets, but overall, beclomethasone, budesonide, fluticasone, and then mometasone. That is the decreasing order. The maximum bioavailability into the system is beclomethasone, then comes the budesonide, then comes the fluticasone, and the last comes the mometasone. So in fluticasone, the furoate versus the propionate, there is one article only which is studied in pediatric age group, not pediatric per se, it is studied in the children between 6 to 12 years, which mentions about the propionate being more having a more bioavailability and causing more side effects, but this is a therapeutic risk. This is just a not therapeutic, theoretical risk. Okay, so but in practice, when we practice, all of us has a favorite molecule. So fluticasone furoate, as far as the efficacy is concerned, I prefer giving fluticasone furoate over propionate. One, because of the efficacy which works better. Second, theoretical risk of the side effects because of lesser bioavailability as compared to propionate.
Thank you, sir. About the second article, sir, this is from John Hopkins All Children Hospital, and out of the presenters in that article, 2 are MD pediatricians and 2 are psychologists.
My question is, what did add to our current knowledge?
Sir, it was a review article and it was showing that increased awareness is there to have a collaborative approach. And it's a review article.
Yeah, so to sensitize pediatricians not to seek the interdisciplinary approach when we are at the end of the road, but in between. Probably that is the only intention.
To start early. Yeah. Sir, over to you.
And actually, may I intervene? May I say one word here? See, the article says that we should, all the pediatricians, first of all, should be trained in developmental pediatrics. And to do the DDST at least or SVELI, all our pediatricians should be trained. And after screening them, you can keep this and invite this psychology, say the developmental specialists to your clinic and work with them at least once in a week with these patients, categorically focused, so that you can think what to do with this. First, you confirm the diagnosis. See, the parents are already worn out. Then they will need your also support, and then a definitive management also planned out for the further course of action. It is the early involvement rather than a late going for referrals. Thank you.
Dr. Jayamal, you wanted to add?
Yeah. In our setting, what we call it as a comprehensive approach, developmental approach, where we are looking at the language, motor, gross motor, fine motor, personal, social. That detailed assessment training is not given to psychologists. It is not part of their curriculum. So maybe they will also need, because they can't assess the motor development or language development or even the personal, social in so much detail like a clinician can do. So probably role of psychologist is more in older children.
Yeah.
Where counseling is important.
A developmental expert can be
So,
involved.
basically, we need to empower pediatricians to, because they are already aware of all the developmental parameters, and they are so nicely trained to handle children, assess children. So a bit of training to pediatrician would be really helpful in diagnosing early and assessing early.
Nowadays it's incorporated, very, very
Yeah, it is incorporated
seriously
also.
incorporated in our curriculum also.
Yes.
Yeah, thank you, ma'am. And I'm extremely thankful to Maha IIP for giving this platform, and we are really blessed with presence of Dr. Piyush Gupta sir, Dr. Narendra Naniwadekar sir, our president of Maha IIP, Dr. Ramakant Patil sir, the main collaborative force, Dr. Amol Pawar, Secretary General. We are extremely thankful, as well as Raigad IIP team of Dr. Vikas More, and our experts, Dr. Jayashree Shivalkar and Dr. Paramarth Channe, who have given their valuable time and inputs for Journal Journey of Maharashtra IIP. The presenters, Dr. Bharat Chaudhary and Dr. Aishwarya Malawde, they have given their best. They have studied the article thoroughly and revised for 3-4 times. We, the team of Journal Journey, are thankful for that. Also, our guide, Dr. Nimen Mohanty sir, his untiring efforts to find out an article starts from today and tonight, or from tomorrow again, for 1st of June. We really thankful for that, sir, as well as other presenters and delegates. The previous presenters I could find out on the screen. Thank you for joining. President of Palghar Academy, Dr. Anjali Gokarna, and Vice President Dr. Jayashree Deshpande are here. Our main backbone of each and every webinar, Women Committee Co-Chair Dr. Neha Singh, we thanks for your support. Our coordinator, Dr. Jay Kumar Bhandarkar's enthusiasm and his untiring effort to have the experts in time and everything to be done. We really thankful for that. And we also thank Dr. Vishal Raut for his support, as well as Mrs. Pallavi Dharmadhikari for the technical support. Thank you very much. Shall we stop the recording now?